Welcome, everyone, to today's webinar, Building a Physical Infrastructure to Support Technology in Healthcare. This webinar is made possible through the generous support of Panduit. I'm HNHN Senior Editor Susanna Hopsolarin. Healthcare technology has transformed the delivery of patient care and improved quality, safety, and efficiency. A high-performing infrastructure is essential for today's providers to feel confident that the technology they are using is reliable and readily available. Structured cabling within a hospital or outpatient facility provides the platform upon which all of the communications, building systems, and clinical technologies are deployed, from wireless networks to security systems and telemedicine and digital image transfers. All of the data, and sometimes even the power to support these applications, is being transmitted via network cabling. This webinar highlights the importance of building a robust physical layer to support healthcare technology that allows hospitals to attract top talent, improve the patient experience, and reduce costs. Our webinar will begin with a presentation by Lindsay Kuhlman and will conclude with a question and answer session. To submit a question to be addressed, please click on the Ask the Question button at the bottom of the console. Simply type your question in the box and hit Submit. Questions can be submitted at any time during the presentation. If you want to download the slides, click on the Materials button. Let me briefly introduce today's speaker. Lindsay Kuhlman joined Panduit in 2012 and is currently a business development manager focusing on the healthcare market. Previously, she held the position of product manager for Panduit's NetKey product line. It's now my pleasure to turn the floor over to Lindsay, who will begin our presentation.
Thank you, Susanna. Hello, everyone, and thank you for joining us this afternoon. The purpose of this webinar is to provide a connection between some of the industry trends in healthcare and the resulting demands on your networks when trying to deploy all of the technologies flooding the healthcare environment. For the agenda, first we'll take a look at some of the business trends in healthcare. What are the factors driving the need and the desire for more technology in a hospital or outpatient facility? After that, we'll discuss some of the technologies that are driving change in the healthcare environment and review the best practices for getting the most out of your cabling infrastructure. Our discussion today will focus on three areas: improving network performance, keeping up with wireless technology, and deploying power over Ethernet. There are certainly many other topics around structured cabling that we could discuss, such as security and cable management, but we just won't have time to fit it all in today. Panduit does have plenty of information available surrounding these topics, as well as others, so if you're interested in learning more, please visit our website at www.panduit.com or send a request during the Q&A section with your email address and the topic you're interested in, and we will be in contact with you after the webcast. With that, let's get started. So what's actually going on in healthcare right now? The short answer is a lot. When we break down all of the regulatory changes, technological changes, and research advancements into their most basic elements, we find that healthcare providers are really being challenged to reduce their cost to serve and increase the value of the care they are providing. Here in the United States, we are experiencing a transition in healthcare reimbursement models that is contributing to much of the pressure providers are facing to reduce their costs and improve the value of their care. Historically, providers were paid using a fee-for-service model. The fee-for-service model is fairly straightforward to understand and decidedly easier to execute than the latest model. However, some people can argue that it can incentivize overutilization of healthcare services, which creates a conflict of interest between providers and patients. The latest reimbursement model is often referred to as value-based care. As opposed to fee-for-service, where providers are reimbursed based on the number of tests or procedures ordered or number of office visits, with really no regard for patient satisfaction, the value-based care model reimburses providers based on the perceived value of the care that the patient receives. The goal of value-based care is to improve the patient experience while reducing the per capita cost of care. The value of care can be measured in any number of ways, but some of the contributors are speed of diagnosis, satisfaction with the overall medical team performance, comfort level at the facility, which can include satisfaction with wireless access or entertainment, food, all of those things, and ultimately the overall cost of care. So what's causing the transition to value-based care? An overall increase in intelligence surrounding medical care by patients, and in the United States, the Affordable Care Act, which results in the consumerization of health care. Just like shopping for a car, patients now have more tools at their disposal for selecting a healthcare provider, turning provider selection into a consumer shopping experience, where reviews, cost evaluation tools, and information aiding with self-diagnosis all help patients select the right provider to fit their needs. As patients transform into consumers, they're ultimately looking for a few things: lower or the lowest cost of care, shorter diagnosis times, more effective treatment, and really convenience, such as finding an office closer to home or work or the ability to pay bills online. As patient expectations continue to rise, healthcare providers are turning to technology to help with a number of cost savings and patient experience improvements. Healthcare facilities are becoming more intelligent as the use of building system sensors, alternative energy sources, wireless, and network devices increases. Through real-time monitoring and technologies such as Power over Ethernet, healthcare facilities can drastically reduce their operational expenses, which can be passed on onto the consumer or as cost savings for care. Improvements in audiovisual technology and increases in bandwidth are allowing doctors and medical staff to conduct real-time data analysis, providing shorter diagnosis times and faster treatment response. In an effort to reduce capital expenditures and improve the accessibility of healthcare, providers are turning to the construction of outpatient facilities rather than large new hospitals. These clinics and office buildings often require the advanced medical equipment found in a hospital, but in a much smaller space. Advancements in cabling design and wireless technology allow us to create the physical infrastructure necessary to support this equipment in a much smaller footprint. And finally, most importantly, investment in the latest medical technology helps hospitals and provider networks to attract and retain the top doctors and staff necessary for attracting a larger patient share. According to a survey conducted by the Healthcare Financial Management Association, healthcare executives have cited three major concerns when bringing on physician employees. The first is operations. Healthcare execs are worried about how to stay efficient and profitable in the face of value-based payments and increasing costs due to technology demands and the addition of extra staff, including doctors. The second concern is compensation. As value-based payments become the norm for hospitals, many executives are struggling with how to pay their physicians. Should they be paid for performance, like the facility, or should they receive a set salary regardless of how well the hospital ranks? And the third concern is recruitment. While more physicians are looking for hospital employment than ever before, and competition is fierce, attracting and retaining top doctors is a major concern, especially since hospitals need to provide high-quality care to survive. While technology can't make the decision around physician compensation, it can certainly ease concerns around operational efficiency and recruiting. Sorry about the delay here, guys. With all that being said, is your cabling infrastructure ready to support the influx of technology required to support modern healthcare? Ultimately, many of the medical technologies that healthcare providers are turning to provide cost savings and improvement in patient experience rely on the same structured cabling networks that we have been designing and installing for years. By selecting a robust, high-quality structured cabling system, You enable the deployment of new technology that is vital for success in the new healthcare environment. Now let's take a look at those 3 topics I mentioned at the start of the webinar, along with some cabling best practices to help you design a network that meets your needs now and well into the future. We'll start with improving network performance. It's probably pretty obvious that as we increase our use of technology, we create more data. How we manage that data becomes vital to our overall success. If your network is outdated or not designed to accommodate the bandwidth needs of new applications, you won't see the intended results of your investments. With the move to electronic medical records and telemedicine, fast and reliable network infrastructure has become crucial to servicing patients both in the office and remotely. New technology like wearable sensors that can provide real-time patient data and the ability to connect home health care direct to a remote doctor relies heavily on the ability to provide constant, uninterrupted data and a reliable video connection. With health monitoring, the actual storage of data isn't so much of an issue because we can easily collect that same information just a few seconds later. However, slow and fast retrieval is absolutely critical. Remember when I said that patient experience is now the key driver for provider reimbursement and overall success in the healthcare market? All of this real-time data collection and analysis enables providers to make quick, informed decisions that help with the speed of diagnosis and path to effective treatment, resulting in satisfied patients. In addition to the increase in patient data collection and retrieval, building automation and intelligence is quickly becoming mainstream and can be an important addition to any healthcare facility looking to manage their operational expenditures. From lighting to window shades, HVAC to locks and security cameras, nurse call systems, all these things, we have the ability to network these devices and remotely monitor them in real time via sensors. And this creates a lot of demand on our network infrastructure, both wireless and wired, that has not existed in the past. As more pieces of our buildings become intelligent, the strain on our cabling will only increase. Long story short, there are now a lot more critical building systems and healthcare data collection tools relying on fast and reliable network performance than we've ever seen before. When we talk about fast and reliable network performance, we're ultimately talking latency. In a healthcare environment, too much latency can mean the difference between the ability to deploy robotic surgery and effective telemedicine the way that you want to. Telemedicine solutions use the hospital network, so it must have high availability and be powered by a UPS connected to critical power. We recommend that equipment used for telemedicine have wired connections. Even if the wireless network can support a telemedicine session, the traffic will negatively impact all other devices connected to the wireless network nearby. When it comes to robotic surgery, it requires bandwidth of at least 2 megabits per second, which is feasible in hospitals with fast private networks, but may not be feasible in rural places with limited infrastructure. Lag is also an issue with robotic surgery. It must be less than 250 milliseconds in order for doctors to effectively conduct surgical procedures without noticing that they're using a robot versus their actual hands. We conducted a survey of healthcare IT professionals to help us understand the current state of healthcare networks and future plans. As we discuss each of the topics, I'll throw in a few statistics that we learned to help put some perspective around what the industry looks like today. Let's take a look at some of the stats around network performance. 60% of hospitals have network cabling that is over 10 years old, and 42% of hospitals have cabling that is over 15 years old. It isn't surprising that we see aging healthcare infrastructure, as replacing it in a hospital can mean a major disruption to service and potential infection control concerns. While cabling is often warranted to 20 or 25 years, we do recommend that you update cabling infrastructure every 10 to 15 years to ensure that your infrastructure is prepared to handle the next demands of your network. When we surveyed the healthcare community, we also found that most hospitals do not have enough ports in many of the work area types specified in the TIA standard for healthcare, including 77% of hospitals who do not have enough ports in patient rooms. And finally, only 50% of those surveyed were familiar with the TIA 1179 standard, which is the healthcare standard for telecommunications infrastructure. Due to the increasing complexity of healthcare technology, TIA, which is the Telecommunications Industry Association, has developed TIA 1179, a telecommunications infrastructure standard, as a resource specifically for healthcare facilities. You can use TIA 1179 to plan and install structured cabling systems, including cabling and pathways and spaces for telecommunications infrastructure, as well as healthcare system requirements, such as RFID, building automation, nurse call, security, access control, and pharmaceutical inventory and dispensing systems. To give you some highlights, the standard recommends the following. Entrance facilities and telecommunications rooms should be larger than typical commercial spaces to make sure you can accommodate the additional systems such as building automation, nurse call, security, and biomedical systems. Equipment rooms shall provide a minimum of 2 diverse pathways between the equipment room and the entrance facility for critical care areas that would be severely impacted by the loss of telecommunication services. These pathways should be separated by as great a distance as possible. There shall also be a minimum of 2 diverse route backbone pathways and cables to each TR or TE that serves critical care areas that would be severely impacted by the loss of telecommunication services. These pathways should also be separated by as great a distance as possible. Telecommunications rooms should not have non-telecommunication services contained within them. They recommend that Category 6A cabling is recommended for new installations. You'll see that as a theme as we go along. They also recommend that you add or change horizontal cabling as little as possible after the initial installation because it introduces the potential to increase the risk in infection control concerns. And finally, ensure that your work area outlet densities reflect the needs of each specified work area. TIA calls out many different work areas, so make sure to pay attention to their port count recommendations when designing a hospital or other healthcare facility. Some of the work area designations are patient services, surgery, procedure and operating rooms, emergency rooms, ambulatory care, women's health, and the list goes on and on. TIA does classify these work areas into density types. Low density, which has 2 to 6 outlets in each area, medium density, which has 6 to 14 outlets in each area, and high density, which has greater than 14 outlets in each area. As I mentioned, the TIA 1179 standard for healthcare facilities recommends Category 6A for new installations. The decision on whether or not to deploy Cat 6A often comes down to budget restrictions. But the good news on that front is that the cost to deploy 10G BASE-T has reached the point where it is significantly cheaper per gigabit than its 1 gig predecessor, 1000 BASE-T. 1000 BASE-T is now 4.5 times the cost per gigabit than 10G BASE-T. When we look here at the comparative per gigabit cost to deploy of 1 gig versus 10 gig cabling and take into account all of the current and future bandwidth-thirsty applications that are flooding the healthcare space, the question of if you should install Cat 6A cabling really comes down to when you should install Cat 6A cabling. As I mentioned, the decision to go with Cat 6A is often a financial decision. The best way to think about it is that you can spend slightly less on Cat 6 cabling today and then pay for Cat 6A infrastructure in the very near future, or you can spend slightly more today and only have to install cabling infrastructure once for the next 10 to 15 years, limiting disruption and reducing the risk of violating infection control measures. You'll see a theme as we continue in the discussion here. All of the recommendations I will make come back to the Cat 6A cabling. When it comes to adding additional stress to our networks, Category 6A provides not only the bandwidth required, but also gives us heat dissipation benefits that come into play when using power over Ethernet. Now let's take a look at some recommendations for wireless deployment. The number of wireless devices and the demand for access to wireless networks in healthcare is growing at an alarming rate. As we've mentioned, we are now able to monitor building systems in real time, many of these relying on wireless sensors. On top of building monitoring, we now have a number of wireless biomedical tools to help predict fall risks and offer a constant stream of data collection for things like vital signs. In addition to all of the building and biomedical sensors, access to a wireless network for entertainment and communication has become an expectation for patients and guests. Hospital staff also require access as well to enable mobile system access and communication. Wireless technology continues to grow in all industries, but for healthcare specifically, it can mean a few very significant improvements to service and cost. Wireless enables mobility for both staff and equipment. For hospital staff, this means being able to access patient records or data on the go, making it easier to keep up to date with their next appointment or recall patient medical history when making important decisions around treatments or procedures. Wireless also enables mobility of medical equipment, making it easier to move the equipment itself or patients between rooms. As I mentioned before, wireless access has become an expectation for patients and guests. Without coverage in patient rooms, waiting areas, cafeterias, and other public spaces, you diminish the overall patient experience, which is obviously detrimental in a model like value-based care. Perhaps the most obvious benefit of wireless technology is the reduction or elimination of the tangle of wires around a patient. With wireless monitoring, the risk of tripping and falling is drastically reduced. If we look at a report from the Joint Commission on the prevention of falls, the average cost of a fall with injuries in a hospital is $14,000 and can extend a patient's stay an additional 6.3 days. In an industry that is being pressed to reduce costs, the more falls we can prevent through the elimination of physical hazards like wires, the better. When we look at the survey data around wireless, it becomes pretty apparent that most hospitals are not prepared to accommodate all of today's wireless demands. Only 21% of hospitals provide wireless access in patient rooms, and less than 10% of them provide wireless access to nurse stations, critical care rooms, and operating rooms. The good news here is that 65% of those hospitals surveyed were taking steps in the right direction in investing in wireless infrastructure upgrades. When it comes to wireless deployment, there are really two approaches you can take. The first step is to ensure you have sufficient coverage everywhere in your facility. 100% wireless coverage provides the patient and staff experience desired and addresses safety concerns. There are many opportunities for interference and dead zones in hospitals, so we do recommend that you have a wireless site survey conducted to determine coverage needs and identify any remediation efforts you may need to address. The other concern with wireless is capacity, which really comes down to the ability of your network to provide reliable, responsive wireless access. I will now discuss a few options for increasing capacity on your wireless network with both existing Cat5e and Cat6 cabling for brownfield installations and Category 6A cabling for greenfield installations. What we're looking at here is a roadmap from IEEE for wireless access points spanning from 2012 into 2017. I know it's pretty busy, so forgive me, and I'll try to simplify it as much as possible. If we start at the left side of the screen, you can see that we're looking across time at three different ranges of wireless access points. Our focus for this discussion will really be the top two tiers. As we look back over the past 2 or 3 years, it's pretty evident that 1 gig Ethernet really has not been relevant for new wireless access points since 2012. As we look at this year, 2016 and beyond, pay close attention to the bottom row, which calls out the Ethernet speed necessary to support the required bandwidth to the access point. We've clearly moved beyond 1 gig here and into 2.5 and even 5 gig requirements, which are being studied as we speak to evaluate the capabilities of obtaining these speeds using existing Cat5e and Cat6 cabling. Beginning in 2017, the bandwidth required for the high-end access points reaches beyond 5 gig, and we will have to use Category 6A cabling to achieve the required Wi-Fi speeds at the access point. My main point here is that wireless speeds are increasing much faster than Ethernet speeds, so installing anything less than Cat6A cabling to your access point is really likely to result in obsolete cabling infrastructure in the next 3 to 5 years. If you'll remember from the previous slide, we briefly went over 2.5 and 5 gig Ethernet speeds. IEEE is in the process of developing a new standard, 802.3bz, also known as Next Generation Enterprise Access-Based T, or NBASE-T. This new standard allows for the use of existing Cat5e and Cat6 cabling to provide additional bandwidth beyond 1 gig for wireless access point upgrades. While we still recommend Cat6a for all new installations, NBASE-T provides the option for you to limit disturbances and reduce deployment costs incurred by pulling new cable when you're trying to increase wireless network capacity. Keep in mind that with NBASE-T, alien crosstalk becomes a concern, particularly when bundling your cable. The key here is bundled length. For longer channels and longer bundled lengths, the risk of the channel not supporting 2.5 and 5 gig over 1 gig cabling is much higher. The majority of the installed cabling in the world has channel lengths less than 75 meters, with some degree of bundling. So likely not 100% bundled for the entire channel length. The shorter the bundled length, the more likely the legacy channels are to support these new applications, providing high-quality infrastructure that was initially provided. Keep in mind that Cat6a, again, will always work for 2.5 or 5 gig regardless of channel length or bundled length. TIA and Panduit recommend installing Cat6a for all new access point installations in order to future-proof and provide the bandwidth required to support the influx of wireless technology that continues to be deployed. As I hinted at earlier, Category 6A is also the most efficient cable to use with power over Ethernet. As seen here, wireless access points are the second most common application for PoE, with expected adoption to reach 80% of access points by 2020. The standards also recommend pulling 2 Cat6a cables per wireless access point to allow for increases in density later on. Again, this becomes very important for healthcare facilities who must take precaution against air contamination when doing MAC work. Now that I've introduced Power over Ethernet, also known as PoE for access points, let's take a deeper dive on that topic. In the chart shown here, you'll see that all applications for PoE are expected to grow through 2020. However, looking beyond access points, the largest growth will come from security cameras, followed by access controls and other building systems. PoE to the desk for VoIP phones will remain at the top of the pack for PoE adoption. As with wireless, there is a new standard in process for the next generation of Power over Ethernet, which will be called PoE++. This opens the door for PoE adoption with many more devices than we have ever seen before. As more devices are able to be powered using category cable, healthcare facilities will be able to improve operational efficiencies through power monitoring and reduce upfront material and labor costs associated with traditional electrical wiring. When we take a look back at our survey results for PoE adoption in hospitals, we find that over 60% of hospitals are currently using Cat5e or Cat6 cabling, which is potentially limiting future PoE adoption. We will see shortly that Cat6a cable is recommended for PoE due to its heat dissipation benefits. 40% of our respondents are looking into PoE for nurse call and building management systems, as well as video conferencing technologies. When we look at the top 3 uses for PoE in healthcare, the responses align perfectly with the data we saw a few slides back: wireless access points, IP security systems, and voice over IP phones. Let's take a look at the latest PoE standards and some cabling precautions to keep in mind. Okay. What we are looking at here is a PoE roadmap, starting with the original PoE standard from 2003, progressing to the latest generation, PoE++, which is expected to be ratified in the next few months. With PoE++, we will be running power over all 4 pairs, rather than just 2 in the previous standards, which provides us a maximum of 71 watts to the end device. A pretty good improvement over 25.5 watts with PoE+. As I mentioned, PoE++ will provide 71 watts to the end device, opening up a whole new world of possibilities for Power over Ethernet. As you can see here, we will now be able to power devices such as POS readers, IP cameras with pan, tilt, zoom, and heating, wireless access points, video conferencing equipment, building management and lighting, and nurse call systems. The big question here with Power over Ethernet is, so what? What is the benefit of powering these devices using PoE over traditional electrical wiring? We really get 4 benefits out of Power over Ethernet. First and foremost, the initial installation offers significant upfront cost savings by eliminating the labor and material costs associated with running electrical wire, in addition to the data cable. With PoE, we're relying on one data cable to provide both power and Ethernet. The second benefit that PoE offers is flexibility in installation. With PoE, the cable may not be required to run through conduit, and the power devices can be located wherever you need them to be, rather than near an existing outlet. In addition to flexibility, we get reliability, which obviously for healthcare is absolutely crucial. Because PoE enables centralized power backup using uninterruptible power supplies, the network is optimized for continuous operation, virtually eliminating power interruptions and downtime. What does this mean for healthcare? We eliminate a lot of the potential downtime and power interruptions for potentially life-saving technologies like nurse call and patient monitoring systems. Finally, PoE helps us be more effective at energy management through remote monitoring and management of power consumption. Because you are able to control the power supply for all devices, you can design for efficiency during off hours. When deploying PoE, there are a few things to keep in mind when it comes to cabling. If you're just running one cable, you really don't have to have anything to worry about here. However, when attempting to bundle a few dozen cables, you really need to watch the temperature rise. TIA has developed TSB 184A to provide guidance on PoE installations. But the most important thing to remember is this. When you're bundling cable for PoE use, the center cable in your bundle cannot experience a rise in temperature of more than 15 degrees Celsius from the ambient temperature. If you're not mindful of this temperature rise, you're risking potential signal degradation and actual physical damage to your cable. To mitigate some of the heat concerns with PoE, we do recommend that you use Cat 6A cable. Cat 6A cable is far more efficient due to its larger conductors. Larger conductors offer less resistance. The more resistance you have, the more power you will lose to heat. Less resistance equals less heat equals less power lost. Ultimately, we found that you lose 27% more power with Cat 5e cable versus Cat 6A when deploying power over Ethernet. All that being said, and I'm sure you're tired of hearing me say this by now, Panduit recommends Category 6A for most new installations. To review again some of the reasons, all of the new technologies that we're experiencing now are really driving migration to 10 gig. The TIA standards recommend Cat 6A for new installations to make sure we meet bandwidth demands. This includes the TIA 1179 standard for healthcare, their standard for education, as well as the data center standard. Those new wireless access points need the bandwidth of 10 gig cable. While we did discuss options for NBASE-T, which gives you 2.5 and 5 gigs over 1 gig cable, Cisco as well as Panduit recommend Cat 6A for all Greenfield installations. And again, Category 6A is recommended for the next generation PoE or PoE++ because of those better thermal properties. It's more efficient cable to use when you have higher power going over your data cable. As a refresher, let's keep in mind the role of technology in healthcare. Technology in healthcare helps us to find lower cost care, pay our bills more easily, hopefully shorten our diagnosis time, improve patient outcomes, reduce the cost of procedures as well as operational costs, eliminate unnecessary visits and/or procedures, and evaluate our providers, ultimately leading to a better patient experience and lower costs of care. So I'll take us back to this slide. Is your infrastructure ready to support the influx of technology? Always remember that a robust structured cabling design enables the deployment of those technologies that improve your quality of care and lower your operational costs. And with that, I'm going to turn it back over to Susanna for our Q&A session.
Thank you, Lindsay. Thanks for your presentation. And we're now going to begin the question and answer portion of today's event. I want to remind you, you may submit a question by clicking on the Ask the Question button at the bottom of the console. Simply type your question in the box and hit Submit. Our speaker will answer as many questions as possible in the time remaining. Questions that are unable to be answered in our allotted time will be shared with the speaker for follow-up offline. And for our first question, Lindsay, for NBASE-T, you mentioned that bundled length is the limitation. What lengths do you have to start being concerned? At what lengths?
So remember that NBASE-T is using your existing 1 gig cabling to get 2.5 and 5 gig performance for your access points. When you are just using one cable, you don't really have anything to be worried about, right? Our concern here is alien crosstalk. So at bundled lengths less than 50 meters, you really shouldn't have any concern supporting 2.5 or 5 gigs with Cat5e or Cat6 cabling. When we move up to something like 75 meters or less, you may start to run into some issues supporting 5 gigs, especially with Cat5e cable, and you may have to do some sort of mitigation there with reducing your bundle size or moving some things around. If you are in a situation where your bundled length is between 75 and 100 meters, which is probably pretty rare, but it could be out there, you should be able to support 2.5 gigs okay, but 5 gigs over Cat5e is very unlikely, and Cat6 is still pretty risky there. So at that point, we recommend that you just pull a new Cat6a cable. Again, there's no risk for Cat6a at any of these bundled lengths.
How many cables can you handle when running power over Ethernet?
That's a tricky question because it depends on a lot of different things. It first and foremost depends on the wire gauge of the cable and the applied current per pair. So whether you're trying to run PoE versus PoE plus or PoE plus plus. The larger the wire gauge of the cable, the better off you'll be. So a larger gauge cable will give you a larger bundle size. The cable construction also comes into play. So if you have unshielded cable versus shielded cable or a quasi-shielded cable that acts like unshielded, you'll do better off with a shielded or something with a protection on the outside for that heat dissipation. The standards test bundle is 100 cables. But ultimately, if you're trying to create larger bundle sizes with smaller gauge cable, you can separate them into several smaller bundles to improve the airflow, and that should solve any heat concerns there.
Do you have recommended applications of shielded Cat6a cable?
It really depends on the application, even within the hospital. So here in North America, we see mostly unshielded cabling being used pretty much everywhere. There are certainly applications for shielded, especially in places like operating rooms or anywhere where you are introducing a lot of additional noise into the space from medical equipment. At that point, you may want to consider going to shielded.
Okay. Lindsay, you didn't mention lighting as a use case of power over Ethernet. Can the new standard support PoE lighting?
So the only answer I can offer here right now is most likely. It's not fully baked yet, but keep an eye out for more information in the coming months on the PoE++ standard. There are PoE lighting applications out there that work just fine today, so that's what I can give you for that answer.
Lindsay, what are your recommendations for shielded or unshielded cabling for hospitals?
I think we already answered that one, Susanna, but just to refresh, it really depends on your application. Most of the time, we're going to see unshielded here in North America.
Okay, thank you. One of our participants heard something about a special cable for power over Ethernet++. Will they need anything other than the normal data cable?
Yes and no is the answer to that. The cable itself is possibly the same cable that you're using today. However, you may need to use LP or limited power listed cable. This is a listing from UL that basically ensures through testing from them that your cable is safe to use for higher wattage PoE applications. There are a few manufacturers out there today that offer LP cable, such as General Cable. Panduit will also have an offering that is LP listed. So you'll just have to keep an eye out for the certain recommendations of your application as to whether or not you'll be required to provide that.
That concludes the time we have available for questions. In the next few days, all attendees will receive an email that will include a link to the archived webinar session. I want to thank our audience for joining us today. Thank Lindsay Kuhlman for sharing her insights on best practices for deploying copper-structured cabling systems to support applications in healthcare facilities. Thank you to our sponsor, Panduit. Thanks again for joining us, and this concludes today's program. Have a wonderful afternoon.